Good afternoon. Welcome to this very special live event, Protect Your Spine, When to Seek Care. This event courtesy of Banner Health. Hello, everyone. I'm Eric Sperling. I will be your host and moderator today. So excited because we have some of the top minds in the field joining us today to discuss this important topic. Andrew Chung, Michael Prim, and Nolan Fisher are here, all fantastic, talented members of the spine team at Banner Health. We look forward to chatting with them in just a moment. But some housekeeping items first, because as you can see, this is a live streaming event. So if the stream goes down at any time or you're having connection issues, we just recommend logging off, logging back on. That tends to fix it. The most important thing, this event will be available to stream and share on demand once the show is over. Some logistics, we'll be bringing our doctors up one at a time to go over some key items related to spine care and the patient journey. And then this is really cool. We're going to have a panel discussion with all of the doctors on the main stage. So we invite you at home to submit questions through that chat feature on your screen. And if we can, we'll try to get to as many of those questions as we can. I already see questions coming in, which is really exciting. So keep those questions coming. Again, we'll try to get to as many of them as we can at the end of the show. But first, let's meet our first guest.
Hi, my name is Nolan Fisher. I'm a physical medicine and rehabilitation doctor at Banner Health. Why do I do what I do? It's because I love getting people back to living their best life. And physical medicine and rehabilitation focuses on function. What's unique about my practice? It's that I always treat other people the way that I would want to be treated. I put my patients' needs above all else. A successful patient-provider relationship with me is all about trust. You can trust that I'm doing what is best for you, and I can trust that you trust in my expertise. I consider communication to be an essential part of my practice because I need you to know as a patient that there are ways for you to get better and get back to living your best life. In the same sense, I need you to know that you need to communicate your wishes with me so that way we can make that happen as efficiently as possible. If there's one thing I'd want patients to say about me, it's that they would recommend their friend or family member to come see me for their neck or back pain.
And look at that, magic of television. You were on screen, now you're here live in studio. Dr. Fisher, thanks for being here.
Yeah, thanks for having me.
It's exciting. We're live. We got a live audience watching online. So how long did it take to grow the hair out after that video?
Exactly how long that took from that video until now.
Fantastic.
So yeah. Unfortunately, I started working here and then my barber retired.
Okay.
So,
it looks great though.
Yeah,
I'm excited to have you here. We're going to talk about spine care. One of the first questions that a lot of our audience was submitting questions ahead of time, and I'll get right to it, is we all maybe have experienced back pain at some time, whether that's, severe or minor. And, that first question becomes, when do I actually seek care? When do I go see someone like yourself when it's just not going away or the pain is so severe? How do we judge when it's time to go see you?
Yeah, I mean, that's a great question. So first off, I always tell people neck and back pain is completely normal. So we see it all the time. I'm sure almost everybody listening here today knows that they've had neck and back pain in the past, and that typically it goes away. There are a few things that we need to definitely point out for people to come seek help from a physician. The first thing is if you have any significant trauma, you're definitely going to want to go see a doctor about it, because that can be a point where you do need an early intervention. In addition, if you have any weakness going down your arms and legs, that's substantial and more than just related to the pain that you're experiencing in neck and back. That would be a time to see a doctor as well. And then finally, if you have any history of cancers or if you're having any bowel or bladder issues, that's always a good time to go talk to a doctor and at least make sure that there's nothing else that's weird that's going on that can be stopped in its tracks.
Okay, so a lot there. Let's talk about the Banner team for a minute. Whether it's physical therapy or I'm having surgery or some of the other things that you mentioned, what's the patient journey like when it comes to your team and how you manage that?
Yeah, so usually patients, when they come in to see me, they've seen a primary care doctor or they've been to an urgent care. And typically it's because their back or neck pain has been hanging around for at least a few weeks. It's more painful than it's been in the past, and it's just not going away with things like ibuprofen, Tylenol, or Aleve. So when I evaluate patients, the first thing I want to make sure is that there's none of those red flag symptoms that I just described earlier. Once we know that there's nothing really concerning going on, the next step is to try to get the patients the most amount of improvement they can get without overdoing the interventions. And that starts with basic things like physical therapy, maybe some activity modification based on your work or what you do. And then we slowly escalate from there. So we actually coordinate with our physical therapy staff at Banner to make sure that we're doing the right sort of therapeutic exercise and modalities. And then in addition to that, we may prescribe some medications just to simply help with pain and inflammation that can allow them to better do that therapy.
Got it. So I don't know if there's a percentage, but how often is physical therapy the answer?
A lot of the time. So I would say about half of my patients that get to me get better with physical therapy or just some simple activity modification and over-the-counter pain medications. And that means that the majority of people actually get better with those steps because a lot of them never even come to me.
Yeah.
After patients come to me, if they do not improve from physical therapy, we start to look further as to why they are having this issue, and that can involve further workup like x-rays, CT scans, or MRIs.
Got it. Okay, Dr. Fisher, thanks for all that information. You're not off the hook yet. You have to stick around. But for now, let's meet our next doctor.
Hello, my name is Michael Prim, and I joined Banner Health this past summer, focusing on spine surgery in the Department of Neurosurgery. I decided to be a neurosurgeon after seeing the complexities of surgery in medical school and was just drawn to the fact of the way to help people in the operating room. When I approach every patient individually, I always try to make sure that I actually listen to what they're telling me and to really understand what their problem is and to give them the best opportunity for me being able to help them with whatever tools I have in my tool belt. One of the best things a patient could say about me to somebody else would be that I actually listened to them, that I was able to do the surgery to the best of my abilities, and that I just provided excellent care overall.
All right, and look at that. Welcome to the stage. All right, doctor, let's talk a little bit about, we just were discussing physical therapy. Now we're going to talk a little bit more about surgery and some of the developments and the advancements in surgery, because for so many years, I think we were talking a lot about minimally invasive surgery. And is that still the case, or are we working on things that are either more intensive or more targeted? Or I guess I'll let you answer that question of how it has evolved and where we're at today.
Yeah, great question. And it's kind of the answer to that is yes, all of that stuff. So minimally invasive is, of course, something that we're always looking at as surgeons and trying to get our techniques a little bit more refined. How do we get patients through the surgeries better, faster, less downtime, get them back up and living life and back to work and things like that. And then on the other side of that coin, the larger surgeries we're also getting better at for the people who need scoliosis surgery or large spine fusions and reconstructions and things like that. The techniques have continued to evolve to get better at those things. So again, if you do a really large surgery, we can still get the patients back up and back to life.
Help me understand better a little bit. Like when you're saying they're getting better, and especially for the bigger surgeries, does that mean like shorter recovery time, or does that mean in smaller incisions? What's better in that?
But it's I mean, we can get into the weeds of the technical nuances of it, but it's how how we can. It's understanding the surgical nuances and the long-term effects of the surgeries, and how we can avoid the long-term complications, even when you do a very large reconstruction on somebody, and how to, we used to put people on bed rest for 3 months after surgery, and now we're getting them up and walking the day after surgery. I don't care how big a surgery I did on you. And it's, things of that nature.
Are those the types of questions that patients come in asking you? Okay. My dad had this done 30 years ago. Am I going to experience the same thing? Is that sort of your patient?
All the time.
Yeah.
I get it all the time. And, I kind of have a spiel that I give about any kind of surgery, if it's a minimally invasive surgery or a large reconstruction. The general timeline is not too different, actually, from all of those things. But, I mean, I can do a very large fusion on somebody, and I tell them, at 3 months, I want you back at work doing normal things.
Okay, and then when it comes to getting more targeted, and we talk about advanced treatment, what exactly does that mean when it comes to becoming more targeted with those surgical options that you have?
Yeah, so I saw a patient actually just yesterday that came in with bad back pain, and it's kind of difficult to figure out what exact surgery they needed. So I actually referred them to Dr. Fisher for kind of a more specific diagnostic test so that I could localize exactly which level is causing the pain, so that then I can target the surgery just to that level instead of kind of taking a shotgun approach and saying, let me just fix your back and hoping it works.
Yeah. And I want to remind our audience watching at home that we do have the ability to answer questions live, so please use that chat feature there. And I'm going to kind of skip ahead because we've got questions coming in, and I don't know if if you guys can answer this specific question. I don't even know if I can pronounce that, but I'm going to give it a try. When restoring cervical lordosis, is it normal? Okay, good. It sounds like you're going to know the answer to this. Is it normal to feel weird things around the neck?
100%, absolutely. So lordosis is the natural curve of our cervical spine or our neck.
Okay.
So the low back lumbar spine and our neck, the cervical spine, have a lordotic curve, which means they curve to the back. Our thoracic spine actually curves forward and it has a kyphotic curve. So people, when they develop arthritis or degeneration of their neck, they can lose that natural curve and people's head starts kind of falling forward. So when I do surgery on people, that's one of the goals of surgery, is to restore that lordosis. And you can imagine that changes the alignment of the bones, of the ligaments. The nerves are now decompressed after surgery, and you get really weird feelings. Numbness, tingling, things just feel different.
Okay.
And that's very normal after surgery. I educate all of my patients on that, for the first several weeks after surgery, you're going to have some good days, you're going to have some bad days. And eventually those days level out, and then you end up at a better spot than when you started.
Awesome. We appreciate the question. Thank you. Keep those coming. You did a great job answering that. What are some of the more common surgeries that you are performing today? You always hear things like fusion. You hear things that you just mentioned. What are some of the more common ones?
Yeah, I mean, fusions are common. I would try to avoid fusions when necessary, or when able, when possible.
Okay.
Let me say it that way. Fusions are a good tool to have in our armamentarium as spine surgeons, but that's not all we do. There's also, I frequently will do what we call decompressions or laminectomies, which is where we just remove part of the spine to take pressure off of the nerves.
Okay.
There's also, I see a lot of tumor patients that have tumors either around their spine pushing on their nerves or within their spinal cord itself and have to take care of those.
Okay. What is the relationship between you guys? We were talking about the team earlier and how that works. How do you guys work with one another?
So the nice part about Banner is we can take somebody that has neck or back pain all the way from the primary care physician and get them good physical therapy with physical therapists that we know and work with. And then they can come see me. And what I can do is exhaust the rest of the conservative treatment options that exist. So while we talked about medications and physical therapy earlier, that's only about half of my practice. Half of my practice is actually doing procedures. They're very minimally invasive, which include injections like epidural steroid injections. They also include things like radiofrequency ablations. And then there's some also more involved stuff like spinal cord stimulation and the like. But my whole goal is to use the simplest possible means to get these patients feeling better. And I would say, based on my practice and based on the available research, I'm able to do that about 70% of the time.
Okay.
And that over 90% of my patients never go on to surgery. But if we do exhaust all the conservative treatment options, that's when I reach out to somebody like Dr. Prim, and we are able to keep this continuity from primary care doctor to physical therapy to me, then to Dr. Prim.
Nice. And we were talking about advancements in surgery. What are some of the advancements in your field that you mentioned the epidural injections? Those have been around for years and years.
Yeah.
Are things evolving in that space too?
Yeah. Well, so first off, epidural steroid injections have been used for 30, 40 years because they work.
Yeah.
The difference between how we do them now and how we've done them in the past is we're much more targeted as to how we treat these patients. So instead of just doing an epidural steroid injection as a shotgun approach, we actually correlate it with the imaging, correlate it with the symptoms, and then we can inject the medication directly around the nerve that's being bothered.
Okay.
This is because of advancements in imaging studies and then just overall techniques, comparing new techniques to old techniques.
And they were, go ahead.
I was going to jump on that. Like I tell my patients frequently, my goal is to not operate on you. And I will very frequently meet somebody for the first time and send them to Dr. Fisher and start the physical therapy and the injections and things like that. And I only see the people after they've completed all of those things and there's no other options.
And then does this journey come back to you after surgery? Are they back in your?
Occasionally, yeah, occasionally that happens. Sometimes what happens are those feelings that you talked about where patients will have nerves relieved and they will get a little bit of a nerve irritation. We'll do a single steroid shot and that nerve irritation goes away. The problem of the pinched nerve was solved by Dr. Prim, and now the steroid injection actually gets rid of the remaining inflammation. And so that can give people then a more sped up recovery process.
I was talking to Dr. Prim about what that patient conversation usually is like with him. How is that in your world? What's the typical kind of most frequently asked question you get from a patient when you see them?
Well, most of the people's concerns are if their pain is going to go away or if they're going to be permanently stuck with pain. The other thing that people are really concerned about is when they hear they have a pinched nerve in their spine, they think about, am I going to be paralyzed? Is this issue going to cause me to not be able to do the things that I love to do? And so I have to explain, what is going on. First off, most pain is just pain because of pinched nerve and not actually causing you to be paralyzed or anything like that.
Okay.
From there, I love to give percentages based on real studies. And I always tell patients that I have with any of my injections, it's roughly around 70% chance that they get better for at least 6 months.
Okay. One of the things I wanted to, wait to some of the pre-submitted questions, but I'm going to jump ahead a little bit because you guys were kind of on that topic here. Pinched nerves, things like that. Does this have a lot to do with how we sleep when we wake up, and whether it's the pillow we're using, the mattress we're using? What would be maybe some of the contributing factors to having a pinched nerve?
Well, I always tell my patients there's 3 things that go into this. One, there is our genetics, and that's just how we're built. The second thing is how we use our body. So if we are doing heavy labor, that may take more of a toll on our back. But in addition, if we're mainly sedentary, that also can take a toll on our back. And we actually find that people who are somewhere in the middle tend to do the best. The third thing is our other medical problems. And so that includes things like smoking, drinking, obesity, diabetes,
That plays a role in
cancers.
pinched nerves?
That plays a role in how our bones and discs stay healthy,
Okay.
which can then lead to the pinched nerves.
Got it.
Frequently what we encounter is, we call it degenerative changes or just arthritis.
Yeah.
People, I got bad arthritis in my neck. And that from things like smoking, diabetes, just not taking care of yourself, your joints degenerate, right? And as they degenerate, things change in the body. And these small little passageway where these nerves pass through can all of a sudden not have as much room, and now you have pressure, and now you have problems.
So how has it changed for you guys when somebody comes in and they've done a little bit of research and they've spent a lot of time on the internet? Are they coming in, diagnosing what they've got, and then you guys have to have that conversation with them? What's the patient education process like these days?
I think it's actually great.
It's really
I mean, the biggest thing to me is that patients being educated with what they see on the internet actually makes sure that we really know what we're talking about. And so it holds us to a high standard. And so I'm able to give patients real hard information that is the next step beyond what is often written about on the internet. The other thing too is that patients will often know what they want done prior to coming in. So they may say, I don't like injections, I don't want needles. And that's fine. We can work with medications, we can work with physical therapy and see if we can prevent them from having to have injections.
Same question. Yeah.
And from a surgical standpoint, it's kind of the same vein that, people come in and like, oh, I don't want that surgery done, I want this surgery done. And, you can learn a lot from Google, but there's a lot of things, there's nuances to how surgery works, let's say. And so that's the job of sitting there reviewing the patient's imaging with them, showing them in clinic, this is your MRI, this is what I'm seeing, this is why I think this surgery is the best option for you since we have done all the other things already. But yes, I mean, the patients come in very well educated, and it keeps you on your toes sometimes. But I think it's a great thing.
And I want to thank we're talking about the internet. I want to thank our live audience for submitting these questions. We've got some great questions coming in. And I do want to just advance to one that, I'm sitting here, we're talking, and I'm looking at your posture.
I did it once
I'm
already.
analyzing my posture, and I'm talking to spine surgeons, and I'm overly cautious about how I'm sitting here. So let's talk about posture for a minute. One of the questions coming in, how does posture factor into back pain?
I think I get asked this every single day.
Go for it.
I always tell people when it comes to posture, there are some postures that are better than other postures, but in general, there's no really one correct good posture.
Really?
Yes, the difference is what we want to do is we want to change how we're moving throughout the day.
Okay.
So if you're standing still in one spot for all day, as Dr. Prim probably knows with his surgeries, that takes a toll on your body.
Yeah.
If you are sitting all day, that can take a toll on your body. But if we get up and we move frequently throughout the day, I actually recommend every 30 minutes. And so if you are a desk worker, this could involve a standing desk where you could adjust to standing, adjust to sit, or simply just taking walks every 30 minutes, walking around the office, or just, even if you go from laying down to sitting up to standing, all of those variables will help with your overall posture.
Yeah, and they call it even little micro breaks. Just, you're sitting there working on a computer, just take a second, lean back, stretch, kind of rotate around. Even that can kind of just help break the monotony and have long-term effects.
Okay, because around the office for a while here, we were giving each other posture checks. We thought we were doing a good job. Like, hey, posture check, and then we do this. So that's not exactly what we should be doing. We should just be moving.
I think like I said, I think there are postures that are better than others. For example, forward rounded shoulders can predispose you to neck issues.
Okay.
It's really hard in our society to keep our chest out like this because
feels
everything
wrong.
is in front of us. So I don't want people to lose their minds trying to keep this perfect posture.
It's funny, we have a live audience. Your marketing team is adjusting their posture as we speak right now. One of the questions coming in, what do you need to watch for with degenerative disc disease in cervical and lumbar spine?
Yeah, I mean, I'll jump on that one. That goes to what Dr. Fisher was talking about at first, and this goes back to that degenerative disease, arthritis that you see in people's necks and backs. The early stages of degenerative disease will lead to some neck pain, back pain, things like that. When you start having symptoms go down your legs or down your arms, that's kind of when it's like, okay, is this maybe something a little bit more serious? The time when it's the things you really need to watch for, or weakness, or the inability to use your hand, or my foot is dragging the floor all of a sudden, I don't really know why it's not working. And that's when you probably need to come see somebody and get checked out.
When I hear the word degenerative, I think older. Is it happening in younger patients, or is that typically something that you see in older patients?
It's typically, I mean, something that we see, and it depends kind of on patients' occupations, right? People, manual laborers might kind of quote unquote wear out before somebody who works at a desk job or something like that. But it is a, we see it more frequently now because we have an aging population. So it is something that as the population gets older, we're just seeing more and more of. It can happen for genetic reasons or people not making the healthiest decisions throughout their life. It can happen in younger patients. But I typically start seeing, most of my patients are starting in their 50s, 60s, and I'm operating on, 70s and 80-year-olds even at this point frequently.
You mentioned, what they do for work, what we do for work being a factor, and this kind of ties into what we were talking about earlier. You were mentioning standing desk, some of the stuff that you see get promoted out there. Is an ergonomic chair necessary for desk jobs?
I don't think it's necessary. I think it helps. I think people run into a lot of trouble when they get chairs that allow them to slouch and then they stay in that position for a long period of time. So I think, there's no perfect solution here, and movement ultimately is the answer. Having a more ergonomically friendly chair, particularly with back support, will help take some of the stress off your lower back.
Okay. Another thing that kind of related to, movement or whatnot, are there certain stretches or movements I can mix into my routine to strengthen or prevent general back pain or neck pain?
Yeah, I actually think the godfather of physical therapy for neck and back pain is a guy by the name of Stuart McGill.
Okay.
And if the audience were to look up Stuart McGill, Big Three, there are three main exercises that he describes there that are generally good exercises for, I would say, about 90 to 95% of people with neck and back pain.
Okay, you're mic'd up, so I can't give you the opportunity to get up and stretch and move all that, but can you describe what maybe some of those are?
Yeah. So there's one of them is just a simple plank, and a side plank is a good example of those. Those are core strengthening exercises that activate the whole core. There's something called a curl up, which is almost like the first 50% of a sit up, where you just bring your shoulders off the ground, and it actually tightens the core muscles. And it's interesting, our core muscles actually act as a lumbar support belt for our back. It's almost a built-in back brace.
Okay.
So when we strengthen those, we actually have more support throughout time of our back. And then the final one is something that's called a bird dog, which is simply, if you can imagine somebody on their hands and knees, they straighten one arm and then the opposite leg at the same time.
Okay.
It works on core stability. It also works on activating the muscles in your glutes and your low back that fight back against some of the postural changes that we've talked about.
And you'll see the common theme with all that is core. It's actually not back exercises or neck exercises.
Right.
It's just core stability to support yourself doing everyday things when you're cleaning out the garage and when you're doing stuff and moving around the house, the core is actually what provides the stability for all that.
That's a great takeaway. Yeah, everybody thinks I got to strengthen my back muscles, but it's actually the core that we're talking about. So speaking of working out, we had a question come in pre-submitted. While working out, I feel pain in my lower back. Should I be concerned about this? How do I fix this? I know that's kind of a general question, but pain in the lower back while working out.
Very common.
Yeah.
Of course, an individual evaluation would be the best thing, but generally people that have achiness in their low back and don't have other symptoms, it's okay to keep working out.
Okay.
And I always tell people that they want to do workouts that don't necessarily make it worse. So if they can walk without making it worse, walking's a great place to start. If they can bike, that's a great place to go. And then eventually to strength training and core strengthening, those are going to be the foundational aspects of a good workout routine. It's cardiovascular fitness, core strength to keep your back strong, and then general overall strengthening exercises to keep your muscles and bones healthy.
All right, fantastic. More live questions coming in. Again, thank you so much for submitting these questions. And apologies as I read some of these cold here, so I want to make sure I get them right. After injections and physical therapy, is it typical to continue to have nerve irritation and or muscle trigger point pain?
Yeah.
You take that.
Yeah, we both
Yeah,
kind of just...
Yeah. No, that does happen. So first things with injections, like I said, 70% of the time it works, which means about 30% of the time it doesn't. When it comes to pain after the injections, because we are putting a large volume of medication around that nerve, there can be a 2 or 3 day period where your pain is actually flared up and you are having more things like muscle spasms or muscle triggering. Our goal is that these injections start to work within 7 to 10 days, and there's been benefits been showed up to 6 months with these injections.
Okay. Next question coming in regarding yoga. Is yoga a good way to exercise the spine with degenerative disc disease?
Yeah.
Okay.
So I mean, again, yoga, I would say generally yes is a good exercise technique because a lot of yoga focuses on the core strength, right? Rotating, spinning, holding crazy positions that yoga can get you in, as long as it's not causing any pain, I think would be a great way to work on certain things. Now, if you turn your neck and all of a sudden your arm goes numb, that might be a sign of you probably shouldn't do that maneuver. Might not have a need of seeing Dr. Fisher or myself, but you might not want to continue doing that. Now, if you do it one day and you get some pain or numbness and it doesn't go away, that might be when it's time to come see one of us.
Yeah, and that was the second part of that question, and you kind of mentioned it there, is, you know, rotating my spine okay, because immediately you think, okay, that could cause some issues, but you're saying that's okay as long as it doesn't create issues.
The spine is meant to move, right? I mean, that's the whole function of it, is to bend, to rotate, to allow us to do these things that and get through our daily lives. And as long as it doesn't hurt and doesn't cause any issues, go for it. But if you start experiencing some of those things we've mentioned, it might be time to get checked out.
Okay, there's a question here that when we were doing this in the tech rehearsal, and our studio crew got really excited about, and okay, here we go. What are the best pillows for side sleepers to prevent pain?
I'm a side sleeper.
I'm a side sleeper.
Yeah, I think
everybody
here
here was a side sleeper. Everybody's raising their hands in the studio saying they're side sleepers.
I would like to say that this is not based off of science or any evidence, but based on my personal preference, the thickest memory foam one possible that can hold your head into a neutral position, I think is the best. But Dr. Prim?
No, I would agree. Again, I don't think there's any scientific articles that say this pillow works better than this pillow. But support, right? You just don't want to be at an acute angle going down. You don't want to be hyper extended this way. So just whatever support and whichever one you use that makes you feel the best.
Yeah,
that's your best pillow.
And we kind of touched on this earlier, but because we're doing this live, and I know we have new people jumping in and out of the stream, like, how much does how you sleep affect your back pain?
A lot.
Yeah.
Yeah. I mean, I think whenever we look at how back pain presents in different people that generally have better eating habits, better overall lifestyle habits, which includes sleep, exercise consistently, and then have better overall health, shall we say, they tend to have less pain or are able to tolerate that pain better. If we don't sleep and we have even a bad night's sleep, we all know it makes us feel worse. And I think that only extends over time if we consistently have bad sleep. And actually one of the biggest things for chronic health conditions is sleep apnea, because people won't get good sleep and they end up having all these other problems that simply stem from not sleeping.
And I mean, it has been shown that poor sleep hygiene or insomnia is a risk factor for back pain or overall health problems. So, I mean, yes, sleeping is important for your back. It turns out sleep is important, and it's just good for your overall health.
Well, you guys have done a fantastic job building this conversation up. We want to advance the conversation a little bit, so we're going to invite our next guest, our next doctor, to come to the stage. Take a look.
Hi, my name is Andrew Chung. I'm a spine surgeon at Banner Health. My patient philosophy is simple. I treat every patient like a family member or a close friend, and I always view surgery as a last resort. And due to my advanced training in minimally invasive and non-fusion spine surgery, when surgery is necessary, I'm able to offer the latest, up-to-date, importantly science-based, minimally invasive and non-fusion spine surgery. I think what I'd want a patient to say to somebody else about me is simple. I'd want them to say something like, Dr. Chung helped me to fully understand my condition, what it was that I was going through, helped me to get better, and through it all, he made me feel like family.
Awesome, and look, we have a packed panel up here. Dr. Chung, thank you so much for joining us live in studio. We've been having a fantastic discussion around spine care, the journey, and so help us wrap up this conversation here as we talk about kind of the overall state of spine care, where we are today. We've had such a good conversation around physical therapy, around surgical intervention, but when it comes to how you kind of answer that question when someone asks you, where are we today? How would you answer regarding the state of spine care?
Yeah, no, first of all, honor to be here, with you guys. Your hair's fantastic, sir.
Yeah, we've
so really a pleasure, and thanks for inviting me. Yeah, that's a great question. I think, I'm sure these guys, covered a lot of, kind of non-surgical, surgical care, where we're at with that. I think the simplest answer would be, we're definitely a lot better than we were 5 to 10 years ago. But I still think that there's a lot of room for improvement. There's a lot that we don't know. And probably where we've advanced the most, I think, at least in my opinion, is not only in our kind of surgical kind of techniques and the technologies that we have, but probably most importantly, it's when to not operate, in fact, and when non-surgical care is probably the right answer. And again, that probably stems from a lot of the fact that, again, we really have not mastered the spine, from a surgical standpoint, from an interventional standpoint. There are spine things, spine pains that we see that we're just like, sometimes we're left scratching our head and saying, I don't think surgery or, an intervention is necessarily the right answer here because, again, we don't know what, the right answer is. So we're a lot better than we were 5 to 10 years ago. I think that there's a lot that we can do now that's much more less invasive from a surgical standpoint to improve spine issues, but I think we have a ways to go, which actually for me is very exciting about our field. I don't know about for you guys. But.
Yeah, I'm going to put you on the spot a little bit.
Yeah, sure.
Next, you mentioned so much has happened in 5 to 10 years. What do you see happening over the next 5 to 10 years?
Yeah, I mean, I can speak from a surgical viewpoint, and certainly we'll let Dr. Prim and Fisher put in their kind of 2 cents, but from a surgical standpoint, I think that motion preservation, more minimally invasive type procedures. So some of us are doing like endoscopic spine surgery, which is probably the least invasive spine surgery. It's almost like arthroscopy of the shoulder or the knee, or laparoscopy for general surgery. So doing some surgeries through tiny incisions. To kind of take care of the problem at hand. Again, not everybody's a candidate for it, but things like that are certainly kind of growing, and it's exciting to see kind of as we take that further 5 to 10 years from now, what the possibilities will potentially be. Things like incorporating artificial intelligence into surgical planning, I think will be very, very useful and be beneficial for patients. Really kind of customizing the surgical plan to each patient's needs and spinal mechanics, I think really is kind of, again, what we're going to see improve over the next 5 to 10 years. And then incorporating that with things like robotic spine care, I do think will be, again, somewhere else where we'll see significant improvements in the next 5 to 10 years to really, from a surgical standpoint, improve outcomes, make them more durable. And the way that I kind of put it is, as reliably as possible when we're doing spine surgery, give as best we can, and probably more so, an A-plus, spine surgical experience.
We still have live questions coming in. We appreciate those live questions. Keep them coming. I want to ask you guys, though, about the next 5 to 10 years. I want to give you an opportunity. What do you guys see happening?
I mean, I think he nailed it from a surgical perspective. I think AI is at the front of everything, and it is making its way into surgical decision making and planning. Kind of going back to when I was talking earlier about large spine reconstructions and talking about individualized surgeries for each patient. Currently when we do a fusion, you get restoring lordosis, right? We talked about that earlier. And we want to make the x-rays look perfect and restore the full lordotic curve and everything like that. Is that actually what the patient needs, or do they need a little bit less curve than what we would normally do and stuff like that? And that's where the AI models can come in and really help that kind of stuff. And then again, we mentioned earlier, the minimally invasive stuff, endoscopic surgery, robotic surgery.
Yeah, hang on, I want to stop there for a second, because endoscopic spine surgery, that hit my ear a little different there. And I'm used to, here's an endoscopy. We've talked minimally invasive for years. What is exactly we're talking about endoscopic spine surgery?
Yeah, no, it's a great question. So some of the guys that kind of have led the charge on developing, spinal endoscopy are almost considering, should we change the name so it's not confusing?
Yeah,
right?
me
Should it
too,
be,
yeah.
spinoscopy or something like that, right? And I can't claim credit for that. I mean, that's
if our live audience, you guys want to vote.
Spinoscopy, spinal arthroscopy, spinal endoscopy. What do you think? But what it is it's essentially, laparoscopy for, abdominal procedures, arthroscopy of the shoulder, the knee, the hip for that matter. They're even doing the wrist and ankle, where you put a camera into in this case, the spine, and the other, depending on the type of endoscopy, essentially with the camera and with use of surgical tools, accomplish still the same goal of unpinching nerves or accomplishing fusion, but through smaller incisions and with higher visualization. And a lot of times what it's allowing us to do, what we're finding for those of us that are really kind of pushing the limits with this, is that for patients that may have previously been considered candidates for like a fusion, we don't necessarily have to do that. We can just do just a little nerve cleaning through tiny incisions and get them home pretty quickly. So a lot of our patients go home same day or maybe the next day at worst with minimal pain medication. So that's, again, not everybody's a candidate for it, but that's basically what spinal endoscopy is in a nutshell. Wow. I don't know if that is enough to
it did. Understanding too, like we went from when we were talking about minimally invasive procedures. Patients could leave with a little Band-Aid covering that incision. So now are we talking about like the smallest incision we've seen when it comes to spine?
It's pretty small. I mean, smaller isn't always better, but I think in this case it is. It's a centimeter or less incision.
Okay.
So pretty impressive what we can accomplish through that amount of working space.
Yeah, I think you got a lot of people excited. We were talking about the next 5 to 10 years and just mentioning things like, oh, fusion may not be the answer. We might have this other procedure that can actually take care of that.
Yeah.
Live questions coming in. I do want to get to one of these here. Is there a number of injections that is considered to be no longer beneficial?
Yeah, that's actually a great question. So whenever it comes to the type of injections that we're getting, that is a big factor of it. If we're talking about an epidural steroid injection, what it comes down to is the patient getting enough relief for long enough that they're okay with it, and that they're not getting too much steroid.
Right.
So in general, I try to limit my patients to a maximum of 3 epidural steroid injections per year. Ideally, I want greater than 6 months relief, so that would be 2 or less per year. In general, it all comes down to the specific patient. A good example would be a young active individual that has a disc pushing on a nerve, and they get an epidural steroid injection and it only lasts for 2 months or so. Then they want to get surgery so they can get this fixed, so that way they can continue to go about their life without needing more injections. However, there are patients that are not good surgical candidates that may have other issues such as heart issues or lung issues. And for those patients, for them to go and get an injection every 3 or 4 months it allows them to be able to live their life and then be able to do the things they want to do without having to go on to see one of these guys.
Okay. One of the things we were talking about is the patient journey earlier in the show, and the difference when guiding someone between what is an orthopedic spine surgeon versus a neurosurgeon. Doctor, do you want to help us kind of navigate that from a patient perspective, how to understand the difference?
Yeah, do you want me to start?
Go for it.
All right. So I think that's an interesting, question. I think most of us now, I'll start with the now. The now is that, most of us now that specialize in spine, call ourselves spine, whether neurosurgeons or orthopedic spine surgeons. If you're modern day trained, on all accounts, I think, it's a level playing field. There are a few things that, kind of classically, neurosurgery probably does more of than orthopedic and vice versa. Probably neurosurgery, deals more with the tumors of, spinal cord and nerves, which are uncommon, but they come up, and I certainly wouldn't be the one to want to take care of that. I would send that to Dr. Prim. And then vice versa, I think, in general, and this is changing as the disciplines become more kind of cross-pollinated, in general, orthopedic spine surgeons were the ones that kind of did the big deformity type surgeries, and they were the ones that kind of pioneered that. Interestingly, here in Phoenix, when I first got back here, there was this bias that I would find in the communities that, neurosurgeons, they do the neck stuff and the nerve work, and then orthopedic surgeons do the low back stuff and the fusion work. And the reality is, when you look at the history of spine surgery, really both disciplines have contributed pretty equally to the development of spine surgery as we know it today. And so the early fusions to that kind of old bias is that, yes, the old fusions were actually pioneered by the orthopedic surgeons in the early 1900s. A lot of the hardware that was invented to put into the spine, orthopedic spine surgeons. A lot of the early nerve work, neurosurgeon probably more heavily so, but oftentimes in conjunction with an orthopedic spine surgeon. If you look at the history, a lot of the minimally invasive type techniques, probably more neurosurgery kind of came up with that. CT navigation, more neurosurgery, robotics, probably a combination of the two. And so ultimately, again, once we get to arrive at modern day spine surgery, if as a patient or referring doctor, you're going to a spine fellowship trained, or either neurosurgeon or orthopedic spine surgeon, you're probably going to get somebody who is facile in all of these things that we're talking about, whether from neck to sacrum, nerve work, fusion. I'm sure Dr. Prim probably does more fusions than I do because he does a lot of the more complex stuff, and then I probably do more nerve work because I do more of the endoscopic stuff. So a lot of what I'm doing is more nerve cleaning, and that's according to the bias here in Phoenix, that would be contrary to that, right? Me doing, as an orthopedic guy, more of the nerve work, where he's really doing both. But point is that, that bias really does not make sense. I think that ultimately, at the end of the day, you just want to go to somebody who specializes in the spine, right? So, you don't want an orthopedist that just does some spine on the side. You don't want a neurosurgeon who just does some spine on the side. It's like, if you have a real electrical problem or a plumbing issue, you don't want a handyman to take care of that, right? Who just dabbles in a little bit of everything. You want a master plumber. You want a master electrician. So whether orthopedics or neurosurgery, bottom line, you want to go to somebody who has focused their training specifically on that and focuses their practice specifically on doing spine surgery. So.
Fantastic way to sum that up.
Very lengthy
I got
thing,
it.
but
Yeah.
I just wanted to get that out there.
Dr. Do you agree?
I would agree wholeheartedly. Historically, I think there were some differences between spine orthopedic surgery and spine neurosurgery, but as time has gone on, it's almost become so much its own field that there's some, not to ruffle any feathers for people that are listening, but does spine become its own specialty? Forget neurosurgeons doing brain surgery and orthopedic surgeons doing shoulders and knees and everything, but do we pull out another specialty of spine surgery? That's a political discussion, but amongst the academics of neuro and orthopedic surgery. But I agree wholeheartedly that it's as long as you see a fellowship trained spine surgeon that understands the nuances of the spine, the biomechanics of the spine, which both specialties do at this point, I think you're in good hands. You know, I tell people frequently it's easy to be an okay spine surgeon. It's really hard to be a good spine surgeon, and that's the difference that he was talking about with the master technicians and things like that.
Okay, so as we wrap this conversation up, I want to give each one of you an opportunity, kind of a takeaway for the audience, a takeaway for the patients, a takeaway for our community here. You know, we talked a lot about the advancements, we talked a lot about the future, the things that maybe you guys are most excited about, the things that you know, when you're out socially and people ask you what you do and how you answer those questions. So, Dr. Fisher, I'll start with you. Like a takeaway for our audience after we're having this discussion.
Yeah, I mean, the takeaway for me is that while we do understand a lot about pain now and we have some great treatment options, I don't want people who have been in chronic pain to think that they have exhausted all the future treatment options. Yeah. This field it's growing so fast. We're constantly doing new research, and I just want patients to know that if they understand what the future would hold, it's looking good to get them good pain relief.
Fantastic. Dr. Prim?
You know, I would say that there are great options, non-surgical options, surgical options for people who are suffering from these diseases of the neck, of the spine, and that we have good options for many different people. If you're not a surgical candidate, we've talked about the treatment options with Dr. Fisher. If you are a surgical candidate, that's mine and Dr. Chung and our other colleagues' job to find the surgery that's best for you. And I think we're getting much better at that than we used to with motion preservation and AI models and things like that. And so, you know, if you do hear that you need a spine fusion, a lot of people get really downtrodden when they hear that or something like that. And it's not a death sentence. It's not that you're not going to be able to live life. We're good at this, and we'll take care of you.
Fantastic. All right, Dr. Chung, bring us home here. Takeaway for our
man,
audience.
that's a lot of pressure bringing it home, huh? So no, I mean, I echo, you know, what all these guys say. You know, I think for spine pain in general, you know, non-operative, you know, care and really prevention is key. And I'm sure, you know, these guys talked about that before I got here. But when it comes to actually, you know, considering surgery, I think, you know, don't be so scared of seeing a surgeon. You know, again, there's a lot of bias of, you know, failed back surgery out there, and I think a lot of that was due to misdiagnosis and probably, you know, the lack of technology that existed when spine surgery was done, you know, a decade, 2 decades ago. And so just because your friend had a bad outcome, you know, 15 years ago doesn't necessarily mean that you're going to have a bad outcome if you have spine surgery now, because again, we've gotten so much better in the last 5 to 10 years. And so give us a shot, you know, come talk to us. And if you're going to come talk to us, again, as we talked about, talk to somebody who's fellowship trained, who practices with modern day principles, and don't be afraid to get a second or third opinion. You know, going back to, like, you know, the handyman or the plumber or the electrician, you know, I always tell my patients, like, listen, when I want to get my water heater replaced, I get 3 quotes. You know, that's my water heater. You know, this is your spine, you know. Don't be afraid to get a second or third opinion, and just make sure that at the end of the day, if you do choose spine surgery, you know, you end up, you know, really understanding, you know, why behind the spine surgery, what to expect after it, and probably most importantly, that the surgeon that you're, you know, going to ultimately move forward with, you know, that you feel like you can trust them, and that, you know, you're that their plan that they've kind of put forth for you really resonates with you before you move forward.
It's fantastic. No pressure, but you nailed it. How many quotes do you get on your water here? You're cracking up.
Too many. I don't want to talk about it.
Doctors, thank you so much. What a fantastic conversation. So valuable, so educational. And I want to thank our live audience for watching and participating. You guys were fantastic. Thank you for those questions. Most importantly, though, as a reminder, this will be available to stream and share with those you know will find this information value. We talked so much about education and getting this in the hands of people who are either considering spine surgery or maybe have considered putting that off. So educational for them to see this and absorb the education we've talked about today. So thank you guys for being here. We thank you for watching. Please use the link after the show, and we'll see you next time.